I'm here with John Kanellopoulos. John, I always learn something new every time that I speak with you. I'm excited about the conversation we're going to have today. Now, you know, we're taught that if a cornea is thinner than a certain degree, or if the patient shows some evidence of ectasia, that we don't want to do any sort of laser treatment. And when we're taught that in terms of naive corneas. You, who've been working with crosslinking since crosslinking, know better than anyone else that the cornea after crosslinking is a completely different tissue. So my question to you is about your wonderful presentation on combining crosslinking with other technologies to address the refractive errors in, number one, keratoconus, and number two, post-keratorefractive keratoectasia.
Of course. Thanks for having me, Josh. It's always a pleasure for me as well. We all know that either primary ectasia in terms of keratoconus or post-refractive surgery ectasia, mainly post-LASIK, is quite challenging to manage. The first indication is to stabilize the ectasia, and I think now globally our go-to procedure is cornea crosslinking. The problem is that in several countries, like in Greece where I practice full-time, contact lens intolerance is very rampant. So only 1 out of 20 patients are able, for instance, following stabilizing their ectasia, to tolerate gas-permeable contact lenses. A little bit better now with the modern scleral lenses. So the patient is still left with a very significant disability to undergo his daily routine. So as early on, it's been over 15 years now that we attempted, and I agree with you, I was trained, and we all know that lasering a thin and sensitive cornea is not our first choice, but in lieu of having a cornea transplant, either penetrating a lamellar, we attempted to laser that cornea, not necessarily do a refractive PRK, but use the topography platform of several lasers and normalize the cornea. This is a very interesting treatment plan to follow, because the laser at parts generates a myopic type correction, and then at parts a hyperopic type correction. And it's an attempt to normalize the cornea center and increase corrected visual acuity. Now, granted, in some of these cases, we induce more myopia, and that is in an attempt not to thin the thinnest part of the cornea. But the gratifying part is that the vast majority of patients, and when I say vast, I mean over 95%, achieve 20/40 corrected visual acuity. And thus, the compelling statistic is that my cornea transplants for ectasia have been reduced by over 80% over the last 10 years.
Wow. Oh, that's tremendous. So when you say corrected, you specifically mean corrected with spectacles?
Or soft lenses, which are, at least in the population that I work and study, a completely different ballgame than using RGP, gas-permeable hard contact lenses, or scleral lenses. And of course, there are several things that you have to deal with down the line. For instance, in some cases where keratoconus, for instance, is asymmetric, you may end up with significant anisometropia, and we all know that's not optimally corrected with spectacles, so then one can consider using a phakic intraocular lens. Now that topography-guided laser has been approved in the U.S., there's a very big interest from U.S. surgeons to engage with this procedure, and we had reported this as the Athens protocol, but I think globally a customized partial topography-guided or wavefront-guided, if it's a milder irregularity of the cornea, normalization of the cornea, and I want to underline this is not a refractive treatment of the refractive error, combined with higher fluence cornea cross-linking, is the #1 choice globally, and I think in the U.S. as well today, for visually rehabilitating these patients. And I think as a transplant surgeon, I think is a tremendous breakthrough to be able to have these young, productive people get back into their norm.
That's really interesting stuff. I've a couple. Well, I have one thing to ask, but I'm going to set it up in a sort of complicated way. The patients with irregular corneas that would require this sort of treatment are likely not the patients with the mildest keratoconus. to the extent that we have a sort of nomogram, a sort of guideline for what cornea, what naive cornea, what thickness is too thin to treat, do you have these sorts of guidelines with the keratoconus patients, or does it depend on the degree of keratoconus independent of the thickness of the cornea?
Well, thickness is a big issue, and we have studied and reported over 1,000 cases over these last 15 years in outcomes. And of course, having 450 microns of minimum cornea thickness is a good window to achieve significant normalization. We have set a standard of not to drop under 380 microns in total cornea thickness. But the interesting thing here is that unfortunately, the Ophthalmic Society assesses keratoconic patients still till the date with Snellen acuity measures. And Snellen acuity is a very poor metric for an irregular cornea, keratoconic cornea. The patient may achieve best corrected 20/30, 20/25 vision, but we all know the optical quality of that cornea is horrendous, especially for activities such as night driving and you name it, any other complicated activity of everyday life that many people do. So I think that if we look at visual performance and visual ability of these patients, even milder keratoconic patients, if they are young, if they're progressing, and if we have decided to go ahead with cornea cross-linking, we offer the ability of that cornea being normalized, and of course these patients do the best. And some of these patients, and just to put a metric on it, on the Amsler-Krumai criteria, even a stage 1 keratoconic eye that is over 450 microns in minimal thickness can essentially become a normal eye, a normal cornea afterwards. Stage 2 can become almost normal, and stage 3 and 4, which are the more advanced, can become competent to a 20/40 visual acuity with spectacle or contact lenses, therefore not necessitating a cornea transplant.
Fascinating stuff, John. Really, really great. Listen, I want to thank you for bringing this wonderful topic to us, and as always, for being so very generous with your time with us today.
Oh, thank you very much, Josh. Thank you.